I'm very excited about this next panel. It was David Brady's idea, and to put this panel together. He'll introduce the other speakers in the panel, but it's such an august group of people, so smart and experienced, that I'm very excited for this particular session right now. And David I've known for a very long time. David's a naturopathic doctor. He was formerly the vice president of the Bridgeport College of Naturopathic Medicine. He's been involved as a medical officer in two great companies, one Diagnostic Solutions, a great testing company, and also Designs for Health, a great supplement company, incredibly high quality, drawing on David's expertise. He's had a practice in Fairfield, Connecticut for a few decades. He's migrated down to Florida. He's abandoned us up here in the cold, but fortunately he comes back and forth a fair amount, and we still communicate regularly and share patients. So without further ado, I'm going to introduce David, who's going to introduce the panel, and take it away.
Thank you, Woody. I appreciate it. Hello, everybody. Thanks for coming to our session. This is a really exciting moment. We have a lot of planning went into this, and we have some great panelists here. We'll have a Q&A at the end, so hopefully we'll save enough time for that. We're going to be talking today about kind of a new classification, or relatively new. It's not new, but as far as medical disorders and classifications go, it's new. And it's something called disorders of gut-brain interaction. Some of the gentlemen that are here on this panel are some of the most esteemed researchers in this field. And some of the learning objectives we'll have in this session include evaluating what is this disorders of gut-brain interaction, or DGBI, and how this new term and category of gut disorders came about. We're going to assess the current state of thinking on the big daddy of the DGBI disorders, which is IBS, including looking at what is the current consensus among top researchers on the etiology and the mechanisms of disease and the various treatment approaches that can be taken. We're going to explore things like the SIBO model, which is very prevalent and popular within the functional medicine community. We'll look at some of the testing and treatment regimens associated with that and how the researchers currently feel about that model. We're going to identify the gut-brain axis issues, including visceral hypersensitivity, and we're going to look at the microbiome and how that may impact these disorders, some of the testing available for that, and finally, maybe even most importantly, how diet and lifestyle factors intersect with this disorder, and how you might find greater ways to have leverage points clinically with your patients. So I'll start with the panel introductions. Woody introduced me. I won't take much time here, but my academic affiliation is as professor and director emeritus of the Human Nutrition Institute at the University of Bridgeport, and my disclosures are Chief Medical Officer of Designs for Health in the nutraceutical space, and co-founder and CMO of Diagnostic Solutions Laboratory in the diagnostic space. So let's start with our panel. We're going to start on the far side. We have Dr. William Che. Dr. Che received his medical degree and training in internal medicine at Emory University School of Medicine. He completed a fellowship in gastroenterology and has remained as faculty at the University of Michigan in Ann Arbor, where he is the H. Marvin Pollard Professor of Gastroenterology. He holds a joint appointment as Professor of Nutritional Sciences, and he was appointed Chief of the Division of Gastroenterology in 2022. His research interests focus on the diagnosis and treatment of disorders of gut-brain interaction and H. pylori infection. He has published more than 450 peer-reviewed manuscripts, reviews, book chapters, and books yielding an H index of 93, which is incredibly impressive. He has mentored more than 70 students, residents, fellows, and junior faculty, many of which are now leaders in gastroenterology. He's a medical innovator and holds several patents. Dr. Che is former co-editor-in-chief of the American Journal of Gastroenterology, and he's authored more than 10 national and international clinical practice guidelines. Dr. Che is a board member of the American College of Gastroenterology, the Rome Foundation, the International Foundation of GI Disorders, and is president-elect of the American College of Gastroenterology. Finally, he has received the Distinguished Clinician Award from the American Gastroenterology Association. He's received honorary membership in the Academy of Nutrition and Dietetics and is the Burke Feiss Award winner from the American College of Gastroenterology. Whew, overachiever. I went out for this panel and got the big dogs, I'm telling you right now. Also here, right to my left, we have Dr. Emmerin Meyer, and Dr. Meyer is a gastroenterologist, a neuroscientist, a distinguished research professor in the Department of Medicine at the David Geffen School of Medicine at UCLA, the executive director of the G. Oppenheimer Center for Neurobiology, Stress and Resilience, and co-director of UCLA's Specialized Center of Research Excellence on Sex Differences, and founding director of the Goodman-Luskin Microbiome Center at UCLA. He has published 430 scientific papers and counting, co-edited 3 books, and has an H-index of 133. He published the best-selling books, The Mind-Gut Connection in 2016, The Gut-Immune Connection in June 2021, and the recipe book Interconnected Plates in 2023. He's recently also produced a documentary film for PBS on the mind-gut-immune connection and is featured in a piece by masterclass.com on the same topic. Welcome, Dr. Meyer. And then finally, I have Dr. Todd Lepine. Dr. Lepine, many of you know, graduated from Dartmouth Medical School. He's board certified in internal medicine, and he specializes in integrative and functional medicine. He has advanced training through the Institute for Functional Medicine. He's a staff physician, along with Dr. Mark Hyman, at the Ultra Wellness Center, located in Lenox, Massachusetts, in the Berkshires. Prior to joining the Ultra Wellness Center, Dr. Lepine was a staff physician at the Canyon Ranch Health Spa in Lenox, and consulted with patients from all around the world who were seeking optimal health. He's a faculty member of the American Academy of Anti-Aging Medicine and teaches for their Metabolic Institute. He teaches seminars on advanced clinical application of nutrition and biochemical laboratory testing. Welcome, Dr. Lepine. He's our functional medicine doctor representative here, along with myself. All right. So, I wasn't showing your pictures. There you go, Dr. Meyer and Dr. Lepine. So we're going to talk about this whole gut-brain connection thing, right? You'd have to be under a rock for the last couple years to not see all over even social media, gut-brain connection, right? And oftentimes it's boiled down to almost silliness in its simplicity on Instagram, right? But in reality, it's a very complicated business, right? It's a very complicated network, an interconnected network between the central nervous system and the enteric nervous system. And, sometimes you see it just, the vagus nerve there, that like schematic diagram, like there's a direct connection, right? It's more complicated than that, although that may be the case. There's a whole interconnected chemical messenger system going on. All of the neurotransmitters in the central nervous system you can find in the enteric nervous system. You have the microbiota composition, which is really a dynamic force in the whole scenario where these microbes can consume neurotransmitters. They can create neurotransmitters. They can consume or produce substrates, to make neurotransmitters. They can change cytokine expression and the inflammatory bias in the gut. So it's a complicated thing, and we're going to explore some of that today. But we do know that people who are generally in a state of good health and well-being have intact functional stress responses. They have a normally functioning HPA axis. They have relatively normal behavior from a mental health status. They don't have depression and anxiety. They have normal pain perception. They have a balanced microbiota, generally. They have more normal gut function, about more balanced immune system, and normal gut morphology. And they can keep that in some level of homeostasis as they maintain their health. Where when we look at people under tremendous stress, people with, classic example, PTSD and hypervigilance-related disorders. We see a dysfunctional stress response. We see altered behavior. We see depression. We see anxiety. We see increased pain perception, even global pain syndromes like fibromyalgia. Generally, if you look, you can see some level of dysbiosis, changes in neurotransmitters, gut dysfunction on various levels, low-grade or overt inflammation, and sometimes even actual tissue damage and barrier integrity problems, which all are rolled up into their disorder. And this is just a modern sort of take on something that's not new at all, right? We all know about E.E. Mechnikov, the great Russian pathologist and zoologist, sixth ever Nobel laureate in 1908, father of the orthobiosis theory and kind of the father of modern probiotic therapy, at least in the Western medicine paradigm. And his famous quote, "Death begins in the colon." And of course, Mechnikov was not the first one to come to this conclusion, right? This sort of philosophy or paradigm threads through traditional Chinese medicine, Ayurvedic medicine, European eclectic medicine, traditional naturopathic medicine. But now we understand it to a much higher degree, with the Human Microbiome Project, and modern testing. We can start putting the pieces together. And in fact, as the microbiome in the gut affects the central nervous system and even mental health disorders, you're now seeing even in popular media terms like the psychobiome, right? So we're going to look at some of that today. So before we actually start the questions, what are the disorders? What is this DGBI, right? Disorders of gut-brain interaction. Well, we're not going to go over all of them and pull it all apart. We don't have time to do that because there are 33 adult and 20 pediatric DGBIs in the Rome 4 classification. But they all share some commonality, and that includes motility disturbances, visceral hypersensitivity, altered mucosal and immune function, including leaky gut or barrier dysfunction, altered gut microbiota composition, and altered central nervous system processing, even to the point, like we said, of global pain syndromes. And many of the things that we do in functional, integrative, and lifestyle medicine actually work along all those different elements. We alter food composition in patients. We change their diet, right? We try to improve it. We try to treat barrier integrity issues and treat leaky gut. We try to alter their microbiota in many cases. We try to reduce their stress, whether it's with some type of therapeutic agent or mind-body therapies or what have you. But we've been working with these DGBIs for a long time. This is just looking at it in a different way. And in fact, when you look at the way these disorders are classified, that generally is by anatomical region. We're going to spend most of our time, as I said, on the big daddy of DGBIs, which is irritable bowel syndrome. And we'll look at the variants of IBS, IBS-C, IBS-D, IBS mixed, IBS that you can't really determine which of those things it really is. And we'll attach some of what we talk to all of that. But the neurobiology of IBS is not simple, right? So it's not a real simple topic to cover in a short amount of time, but these experts really have a depth of knowledge to be able to boil us down to some stuff that I hope is really usable for us clinically. So with that being said, we're going to start some questions here, and I did not disclose the questions to the panelists. All right? So they didn't get a chance to overthink these. In fact, think about them at all, other than we did have a little bit of a, sort of a chat on general topics we were going to cover, but certainly not the questions. So I'm going to direct questions that I formulated to one of the panelists, but the other panelists are welcome to then comment or join into the conversation. And then, did any of the panelists want to make any kind of opening statement? Yeah? Because we talked about you can have like 3 minutes to say something. You guys all good, or you want to go to the questions?
So just a short intro.
Yeah, sure. Do you guys have the mics? Okay. Oh, I thought you each had one. Okay, we're gonna have to pass the mic.
Yeah, so I'm delighted to have been invited to this conference. I'm probably an outlier in a functional medicine conference because I'm not a functional medicine practitioner. I've spent some 45 years in my career at UCLA, mostly studying brain-gut interactions, and before that, even during medical school, I've been interested in brain-body interactions, so that's why I went into medical school. So it's remained a passion for me. We thought at the time the lowest hanging fruit was IBS in terms of a brain-gut interaction. That term was not really accepted by my colleagues or by the Rome Foundation. It was always emphasized this is a gut disorder, don't make the mistake and bring the brain in here. Finally, some 5 years ago, it did happen. I'm happy about this. We were surprised that about 7 years ago now, when the first microbiome papers came out, particularly the papers from John Crine and Steve Collins about interactions of the microbiome with the brain. I was very skeptical. I didn't really believe those findings in the beginning. But since then, have incorporated the microbiome as an essential pillar in our studies of multimodal integration of the brain symptoms, the gut and the gut microbiome. And I think the kind of concepts that have come out of this research, being a scientist, we always had hypotheses. I've rejected them many times during my career. And I personally think that the view that I've derived, which deviates, as you will see in this meeting, in many ways from the traditional dogma. And I still feel pretty strong about this, sticking to my own concepts. So.
Great. Anybody else? I think you have a microphone right here, so pass that one. Okay. Yeah.
This is probably a little bit preaching to the choir, but it's so exciting to get to a time where we're not just thinking about medications. I'm talking about from the Western physician side. I started out my career doing most of my research on new drug discovery and validation. And over time, what I came to realize, and this is, again, I think you'll identify with this very closely, is that patients, for a whole bunch of reasons, didn't want medications. There were a bunch of patients that didn't get better with medications. There were a bunch of patients that couldn't tolerate the medications because of side effects. There were a bunch of patients that couldn't afford the medications. And over and over and over again, patients would say to me, what can I do about my diet and my lifestyle that might help me with symptoms? And when I started on this in the 1990s, there were no evidence-based diet or behavioral strategies for patients with DGBI and specifically IBS. And at that point, I made a decision to shift my lab towards more non-pharmacological therapies. And our group is the one is the only group that's done a randomized controlled trial validating the low FODMAP diet in IBS. We were the first group to publish an RCT on kiwi for chronic constipation. We've now iterated and developed a diet called the FODMAP Simple Diet, which we have an NIH grant in for right now, that will actually be a truncated version of the low FODMAP diet that excludes just fructans and galacto-oligosaccharides. And I could go on, but the point is that it's not just us. There's actually now multiple groups around the country that are getting very interested in this, and it's really picking up steam. In fact, we just last year added a GI acupuncturist. We're the first large academic medical center in the country to have our own GI acupuncturist. In fact, that person now has a wait time of 3 to 4 months. We're actually adding a second person. So this whole area is really picking up steam, and I think it's an incredibly exciting time, not the least of which is because in 2026, Rome 5 will come out. And Rome 5 has really embraced the integrative care model, so diet, behavior, as well as medications, as equal partners. So I think our disciplines are starting to come together, which I think is a really, really exciting thing. We can learn a lot from you about being a bit more forward-thinking and taking more risk. And hopefully you can learn from us as we do the research and validate some of these different interventions with properly designed randomized controlled trials.
Excellent. Thank you. Todd?
Okay, so my background is I started out as a country doctor in Stockbridge, Massachusetts, and I first became interested in the gut-brain connection when I was an intern and I was wet behind the ears. And I had a patient in the VA hospital. I'll never forget it because this is what started my curiosity. I'm a little bit like Curious George. And the patient came into the emergency room in a coma, and he was non-responsive at all. And I never even heard of hepatic encephalopathy. So for those who don't know about that, that's when your liver's not working and the toxins from the gut affect the brain. And what we did with him is we treated him with neomycin. We gave him a laxative called lactulose. And we also at the time, which is ahead of the time, we also gave him probiotics. We gave him whatever the lactobacillus that the hospital formulary had. And within less than 24 hours, he went from being in a coma to Lazarus. He woke up from the dead. And I'm like, wow, that was amazing. And I'm like saying, well, what was going on with this guy that his gut and his liver was making him go into a coma? And that was what got me started on the road of the gut-brain connection. And it's a fascinating road. It's taken me down all different pathways. David and I have lectured around the country and around the world talking about the microbiome and the effects it has on our health and specifically the brain and how they're all interconnected. And I was really trained as an internal medicine doctor, but I've evolved into functional medicine. And if I take, I'm at a cocktail party and somebody asks me, what kind of specialty are you? And if I say functional medicine, most people don't get it. Like they don't know what functional medicine is. So I give them a mouthful and I say, I'm a psychoneuroimmunoendogutologist, which is basically what internists do. They sort of connect all of the different parts of the body. And to some degree, I was glad that I trained as an internist because I have a whole body perspective on it. I'm not stuck on just one organ system. I'm curious about the immune system, I'm curious about the brain, I'm curious about the gut, and how it's all interconnected.
Thank you. Well, we're going to have some questions that actually delve into many of those things that you all already brought up. So I think we'll be able to dig a little deeper under the hood on some of those things. And as I ask these questions, I've, in many cases, picked out some of the actual panelist research up here that might relate to that question. So when you get these slides afterward, you can always go back and read the full studies and pull those papers. The first question is going to be for you, Dr. Meyer. And it is this. Based on your extensive experience as a researcher and a clinician, you've written that the growing body of evidence in the research, paired with clinical observations, supports a critical role for the brain in the generation and the maintenance of IBS symptoms. And regardless of the primary symptom triggers, you say the brain is ultimately responsible for the construction and the generation of the conscious perception of abdominal pain, discomfort, anxiety, based on sensory input from the gut. So you describe basically a brain connectome. And this is sort of a new model of IBS. Do you think that this is yet influencing the therapeutic approaches that are being taken in IBS?
Well, I mean, I think, if you take a holistic approach to a patient, it will always address both the gut and the brain and the mind and, worries about pain, predictions about pain. All these things, the brain integrates, and ultimately, as I just said from this quote, what somebody experiences has to be processed and modified in the brain. And there's memories that play a role in this, past experiences, traumatic experiences, but also take into account that there's this 24/7 communication between the gut and its inhabitants, this 100 trillion microbes, with certain areas of the brain, the vagus nerve being sort of one of the main conduits of communication. So it's the symptom expression is a very complex phenomenon. I personally think, I mean, there's probably no question, is that the conscious experience and the personal reaction to these experiences, come from the brain. And when a patient presents with certain symptoms and which are often kind of vague in these gut-brain disorders. I think without addressing those, you will not have a lasting improvement of the symptoms. So the patient has to understand it, has to see the reason how these symptoms come about, and has to be willing, has to accept the model, the brain-gut model, and then has to be willing to make the changes that include the diet, that includes the lifestyle, that includes other, health-promoting factors. So that's
great. Okay, thank you. We're going to go to Dr. Che. One of the reasons I really wanted to have you on this panel because of your focus in your work on diet. And we're functional integrative medicine, lifestyle medicine doctors, right? So we should have diet and food as a very prime concern in how we approach patients. So, and you've researched all this stuff, particularly as it relates to DGBIs. So, as such, the literature suggests up to 80% of IBS patients report food as a trigger for their symptoms. Most attempt dietary changes of one form or another, right? They try eliminations, they try to improve their symptoms with all kinds of different approaches. You mentioned FODMAP, but what is it that you do feel generally works best as an approach to these disorders? Is it FODMAP? Is it some combination?
So there's a couple different ways to answer this question. Okay, so if you were to ask what is the most evidence-based diet intervention for IBS, it would be low FODMAP. But realize that low FODMAP makes the majority of IBS patients better, probably 50 to 60% of patients better, but that means that 40 to 50% of the patients don't get better with low FODMAP. And so it's really important to view the low FODMAP diet, in my mind, as getting the foot in the door so that people are now thinking about and recognizing the importance of diet. But it's really just one possible treatment option. So for example, one of the papers that we have in review right now that hopefully will be published very soon is the first US pilot trial for the Mediterranean diet in patients with IBS. And there are now several studies from around the world, not the US, that suggest that the Mediterranean diet might be very beneficial. And why does that matter? Well, a couple of reasons. First, Mediterranean diet is not a restriction diet, okay, unlike the low FODMAP diet. Mm-hmm. And remember that the low FODMAP diet is not appropriate for a lot of patients, meaning that if patients are engaging in overly restrictive behaviors in regards to their foods, you should not be recommending a restriction diet like the low FODMAP diet. Right now, it's so funny that in 2007, I was one of the first people in the United States to talk about the low FODMAP diet. Literally at a postgraduate course at a GI meeting, I talked about this, and my colleagues were almost throwing things at me. They were so upset about this concept of using a diet for IBS. And now in 2025, how do I spend my time? Talking people out of using the low FODMAP diet. Now, it's a very useful diet, but it's not for everybody. And you have to understand, where is it appropriate, where is it not appropriate? And so Mediterranean diet's really exciting because it gives you a non-restriction option for patients with IBS that, by the way, offers huge benefits for cardiometabolic health, a whole variety of other non-GI related outcomes which are very important, cancer risk reduction. So I think the answer to your question is, it depends. It depends on the specific life experiences and needs of an individual patient in terms of what to recommend. By the way, the other thing that I didn't mention is that the NICE guidelines, which you may be familiar with. They're recommendations from the British Dietetic Association, just common sense dietary recommendations about making sure that you eat 3 meals a day, but you don't overeat. You avoid certain types of sugar alcohols. You eat enough fiber, but certain types of fiber. Those will turn out to work in about 40% of IBS patients. 40% of IBS patients will get better with just these common sense, basic dietary recommendations. So the point is that it's not just the low FODMAP diet. You have NICE guidelines, you have low FODMAP diet, you also have now the Mediterranean diet, which are all evidence-based diet interventions. Not to mention the fact that, not to mention the biomarker-based diet interventions, which we can certainly get into if you want.
Great, thank you. Todd, your turn. So, as a functional medicine doctor, you know, we deal with train wrecks, right? We deal with people with complex chronic disorders. They're usually not new things. They've been around for a long time. They've had this long, unwieldy medical journey through multiple providers. They often come in, as we say, with rattling bags of drugs, rattling bags of supplements, charts this thick with every test known to mankind. Usually they've already had double headers, right? Endoscopy, colonoscopy. They couldn't find anything. You know, maybe they've been put on a PPI, right? Things got worse. I mean, it's, you know, we see it all day long. What are your biggest challenges in dealing with these chronically ill patients that usually have a significant gut component to their laundry list of complaints?
That's a big open-ended question because there's so many things that play a role in what we call IBS. And I'll just give you a couple of examples. I once did a podcast with Mark Hyman on IBS. And in the talk, I mentioned the role of nanoparticles, specifically titanium dioxide. Now, maybe most of you aren't aware of that, but it's added to foods. It's a whitener. It's in toothpaste, it's in gum, and it's also used in sunscreen. And I mentioned this on the podcast, and this woman in Australia was using titanium dioxide every day on her skin, and she had IBS. And she said, oh, I wonder if there's a connection. So she stopped her titanium sunscreen, or titanium dioxide containing sunscreen, and lo and behold, her IBS went away. I was like, and so she emailed me and said, you know, this is just wanted to let you know, I heard you on the podcast, and I just stopped using titanium dioxide, and my IBS went away. Yeah. So it's you know, that kind of thing. Then I had another patient recently, because, you know, IBS, I call it an unhappy gut. You know, you have an unhappy gut, you have an unhappy brain. And when the gut's happy, the brain tends to be happy. And I had another patient who was on gabapentin. She came into me for, her main complaint was IBS, but she had some other things too. And she was on gabapentin, she was older, she was like taking 100 milligrams 3 times a day. And I said, well, you know, is this medicine, I think she was taking it for some mild neuropathy symptoms. And I said, is the gabapentin helping? And she said, no. And I said, well, why are you still on it? So the first, you know, one of the first things that I look at with my patients is what I call iatrogenica imperfecta. If they're having problems, the doctor probably caused it. And I told her, I said, why don't you slowly get off of it and wean off of it? On her first follow-up, she slowly weaned off of her gabapentin. Lo and behold, I wasn't expecting her IBS, but her IBS completely went away. Completely.
Wow.
Yeah. And then other things to be aware of, because we live in a land where we're all consuming, you know, for better or worse, if we're not aware of it, is processed foods. And a lot of our processed foods contain emulsifiers. Emulsifiers are designed to break up fat. And when people have diets with high emulsifiers in the food, that disrupts the mucosal lining of the gut. In addition, another thing that should be on your radar is dishwasher soap. What does that do? It gets rid of fat on your dishes. And dishwasher residue from some of these real potent dishwasher soaps is actually also directly associated with affecting of the mucosal lining. So those are things that I oftentimes will think of when I'm seeing someone with IBS. And then obviously the gut microbiome plays a big role with IBS. And one of the things that I have found, and this is my own observation, is that when I see people with refractory gut issues where I'll do some testing on them, I may do some interventions with them, and they get better, but then their symptoms come back, is I start looking at the oral microbiome, okay? Now, a lot of doctors and even dentists it's not even on their radar. So our oral microbiome, we constantly swallow our oral microbiome. We also get exposed to the oral microbiome through kissing and intimate contact. And that can be also another source of potentially upsetting the gut. So those are some of the things that I'll think of when I see patients who are complicated. And then obviously, I always will ask about trauma, which they may not even recognize as trauma. They'll say, "Oh, that happened. My father used to beat me, but I'm fine now." It's no, you're not fine now. Or they had some type of early childhood trauma, and that sets their stress response to be more heightened when small interventions happen, consciously or unconsciously.
Right. Well, it's a good lesson in keeping a wide lens perspective when dealing with these patients. Did you want to follow up on that, or are you good? You looked like you were itching to say something.
Yeah, I mean, I do agree with some of the things that have been said before. Just to comment on, I also see that same spectrum of patients, 5 colonoscopies, I've seen several physicians. Nowadays, the last 5 years, they come with my first book in hand, The Mind-Gut Connection, and say, "I'm patient so-and-so in your book, and can you explain more about this?" So I don't get referrals anymore, they're all self-referred. And so just a comment about the diet, my own personal view, having looked at this closely, I personally feel there is a human default diet in certain geographic locations of the world. It's different in the polar regions based on temperature and availability, but I think a Mediterranean type diet, which could be Asian, which could be from other countries, but with a high percentage, 75% of plant-based food, is the best for the general health. And I think I say this because it's definitely the optimal diet for the microbiome, because they thrive on the components, both the fiber and the polyphenols that are contained in that kind of food, and produce anti-inflammatory short-chain fatty acids, produce sufficient amount of mucus to improve the lining of the gut. So it's kind of an easy answer to that. What has to be done with that diet, a lot of IBS patients are sensitive to gas production, physiological gas production by the microbiome. So if somebody has that phenomenon and can nail it down based on the diary, that there's this handful of items that they don't read about the FODMAP diet, but they find out themselves. Once they find these agents, they either reduce the amount or they eliminate them from their diet. I would say 95% of my patients are on that kind of personalized Mediterranean style diet, patients with IBS, and do not have the symptoms. A big part of the symptoms is also this anticipatory anxiety, what's going to happen. Patients are being bombarded on the internet with information about what's bad for their gut health, and this information is stored in the brain, and the brain makes predictions. Or if I get close to that food that somebody talked about in the past, I will get these symptoms. So this is a big part of it. The second thing with the causes of IBS, I mean, I have spent the better part of my career dealing with IBS patients, both in the clinic and in our research studies. I don't like what most research papers start with. IBS is a complex disease. We still don't understand it. I think we understand a lot about it. And just certain aspects of it, biological aspects like the increased sensitivity, not just to distension and contractions, but to food items, to gas, to even non-intestinal stimuli. And the other one is this altered autonomic responsiveness. the enteric nervous system is the third part of the autonomic nervous system. So an imbalance of how the autonomic nervous system reacts combined with this increased sensitivity, which comes in different degrees. Some people have it mild, just on the gut. Others have it throughout the body. Then they have other pain syndromes associated, these so-called comorbidities. So without getting into the length of this, I personally feel that we understand a lot about IBS. The latest addition has been the microbiome, which does not cause IBS, but plays some modifying role in subpopulations. So I don't start my own papers with that sentence, pathophysiology is not understood. I think that's just not true anymore. And I would imagine, my colleagues here would agree with this, from different angles.
I'll tell you one thing that's really important when you're talking to your patients. Don't say you have IBS. We have no idea what that means or what causes it. Talk about creating a panic for your patients. And I think what Emran says, there's a lot of truth in it, which is that the physicians that are most successful at treating IBS patients are those that can explain the concepts of IBS to the patient in a way that they understand. Because, what's fascinating is that a lot of times when you're talking to an IBS patient and you're successful, they'll come in after your initial visit and you'll say, how are things going? And they'll say, great, things are going really well. Okay, well, tell me about your bowel habits and your abdominal pain and your bloating. And they're still having all of those symptoms. But because they understand why they have it and because they have strategies on how to deal with it from day to day, they're actually okay with it. And the reality is that our goal for IBS patients is not to get rid of all of their symptoms. It's to make their symptoms less bothersome to the patient, less frequent, and for them to understand why they have their symptoms and what they can do to try to control them. I think that's a really critical thing to understand as you're taking care of patients with these conditions.
Well, let me follow that up because I agree with you, and doctors like all of you understand this, and you frame it that way with patients. But, when is it going to change the way the community-based gastroenterologist deals with IBS patients? I haven't found that to be the case yet. Maybe it's just a limited sample. But I don't see when patients have gut problems, they generally end up at the gastroenterologist at some point, right? Or we refer them there. And it's not been my experience that they get that kind of care.
That's right. And the reason why is because the model for caring for patients with DGBI, IBS specifically, is that the gastroenterologist views their main role as scoping the patient.
Yep.
And most of the cognitive care is actually delivered by APPs now. Mm-hmm. And that's fine. Like if the APP is and a lot of our APPs, for example, are extremely facile. They're very experienced at this. They're very good at delivering that kind of care. But for the most part, gastroenterologists don't want to deal with the cognitive part. I don't know, Emran, if you would disagree with that or agree with that, but that's my sense is that people are much more interested in scoping now and less interested in actually.
And that's the financial model of the practice.
Yeah,
right?
I mean, that's just the reality is if you pay
Yeah.
people to do endoscopy, that's what they're going to do.
I would just add that oftentimes to give the patient something when they leave the office is they give them a PPI, the purple pill or whatever. And that actually is like throwing gasoline on the fire.
Yeah.
I mean, they're better off not giving them a placebo.
All right.
Yeah, it's either it's either PPI or it's anxiolytic, or antidepressant. I mean, 2/3 of the patients I see are on those medications that they don't even indicate to you as a medication because it's become such a habit for them to take it. But I was going to make a comment on the situation has actually changed in the last few years. To my big surprise, I mean, IBS was not a topic for a dinner conversation. Most people were embarrassed to talk about things like bloating and gas to others. So something has fundamentally changed in the last few years with the brain-gut connection or the gut health concept has become so popular on social media that now all of a sudden, if you do a survey, there's a survey, I think that 60% of people complain of gut issues or having an unhealthy gut. So that didn't exist. So before it was narrowed down to IBS, defined by symptom criteria. Now a lot of people have these symptoms that they feel, and it's a wide range from just not feeling good to feeling fatigued. Everything is being called now coming from the gut. So it's an interesting phenomenon, and I don't know, how to deal with this, because the gut is, in my opinion, particularly the way it talks to the brain, a key organ, homeostatic organ that underlies a lot of diseases or contributes to it, but it doesn't cause all these symptoms by itself. I mean, it's a player in it.
I think it's just sort of a concept that even resonated with the general public because of, it just makes sense to them in some way. You feel your emotions in your gut, right? You get stressed, you get an ulcer. I mean, all those things that people think of, they do kind of have this just even cultural mindset that the gut is somehow connected to the brain and our emotions. They just seem to intuitively know that. Let's go back to diet for a minute, Dr. Che. This is one of your papers where you talk about specifically FODMAP here, but it can be any dietary intervention. But you were talking about the difference in responders, how someone responds based on if they're constipation dominant IBS or diarrhea dominant IBS. So these various subtypes. What are clinicians to do? Use the same kind of dietary intervention as a first salvo, regardless of what subtype they have, or should we pay attention to that?
Yeah, this is an important concept to understand, because I think there's a lot of misperception out there. People have, for a long time, suggested that the low FODMAP diet is really a strategy for patients with IBS and predominantly diarrhea. And the logic behind it is that if you introduce a large osmotic load into the colon, that's going to lead to water secretion, which could cause diarrhea. And so intuitively, it makes sense that might be so. It turns out that if you carefully analyze the data from all the randomized controlled trials on the low FODMAP diet for patients with IBS, that the two symptoms that most consistently get better in patients that respond to the low FODMAP diet are abdominal pain and bloating, not diarrhea, interestingly. Diarrhea does get better in a lot of IBS-D patients, but not as consistently as abdominal pain and bloating. And so it begs the hypothesis, well, if it's pain and bloating that you're making better, maybe IBS-C patients who have a lot of pain and bloating might also benefit from the low FODMAP diet. So this study actually is a real-world experience amongst hundreds of patients with IBS of all subtypes that basically shows that pain and bloating gets better in IBS regardless of which subtype you fall into. So for pain and bloating, you could still use low FODMAP in IBS-C patients. I think that the logical, reasonable thing to do is to treat the constipation first, and if the pain and bloating get better, great, you don't need to do anything else. On the other hand, if you still have residual pain and bloating, the low FODMAP diet would be a very reasonable thing to layer on to address those symptoms. So low FODMAP would not be a primary strategy for IBS-C, but it might be a very nice adjunctive strategy for pain and bloating.
Thanks. Dr. Meyer, everyone's pretty much seen this book, right? Michael Gerson's popular book, The Second Brain. It's been out for a long, long time now, but it kind of was part of creating this concept that the gut kind of has a mind of its own, so to speak. But you have been, Dr. Meyer, you've said that this notion of the second brain is really maybe not correct. You tend to refer to it as the first brain, right? So can you explain that?
Yeah, so make a very long story, 4 billion years short. So the microbes were the dominant life form in the oceans of the planet for 3.5 billion years. learned a lot during that time to communicate with each other, stored a lot of information in their genome. They have the biggest genome per organism, a lot more, 100,000 times more than we have in our genes. And so at some point, about 500 million years ago, some microbes, probably by coincidence, started ending up in one of the first marine animals, a floating digestive tube. And in that digestive tube was a comfortable place. The microbes were taken around by this microorganism. And so a phenomenon happened, what's called lateral gene transfer. The microbes transferred some of their genes to the host, to that primitive marine animal. And if you look at microscopes, micrographs of the nervous system of that marine animal, it looks exactly like the enteric nervous system. So then these neurotransmitter precursors were transferred, the genes were transferred from the microbes into that skeleton nervous system of this animal and became the first neurotransmitters. Later, they migrated up when animals developed brains, they migrated to the brain. So ultimately, I mean, the microbes were the origin of the transmitters in our brain. But the nervous system in the gut was really the first brain. And remarkable that over hundreds of millions of years, the design and the architecture looks almost identical. If you put the images next to each other to an enteric nervous system picture. So evolution has stayed with that design of the first brain, which nowadays regulates GI functions, particularly any GI function. You can cut it, Dr. Gershon always shows it, you can cut the gut off from the brain and it still creates peristalsis and functions. So what happened when the nervous system also moved to the brain, there was a division of labor. The brain took care of other functions of the body, and the little brain in our gut basically focused on gastrointestinal function, secretion, blood flow, and motility. So I think I've often talked to Mike about this, and yeah, I mean, this book was very successful. He certainly wouldn't change the name of it, but it is, the enteric nervous system is our first brain.
Thanks. All right, we're going to delve into an interesting topic here, including visceral hypersensitivity. The literature certainly suggests that changes in the GI microenvironment contribute to the development of visceral hypersensitivity in IBS and functional diarrhea. With a focus on immune activation and neuroimmune interactions, including activation of eosinophils and mast cells, impairment of barrier function, reaction to foods and the diet and the microbiome, can either or all of you comment on the role specifically of histamine, mast cell activation, and how the microbiome composition, including organisms that can produce a lot of histamine like Klebsiella aeruginosa, may be involved in this? Just visceral hypersensitivity, histamine.
I'll start off. So this really brings into play this emerging concept that's gaining popularity about the role of mast cells in the pathogenesis and perpetuation of IBS. I'll just give you a snippet of how this may work from our own work. In basic translational studies with the low FODMAP diet, it turns out that if you put animals on a high FODMAP diet, they favor a gram-negative dysbiosis, including Klebsiella. And Klebsiella is a very prolific producer of LPS, lipopolysaccharide. Mm-hmm. Lipopolysaccharide, as it turns out, has a deleterious effect on intestinal permeability. So more stuff gets through from the intestinal lumen to the gut immune system, which leads to activation. And it turns out that in animal models, you can very nicely demonstrate that there's mast cell activation and release of histamine. So That's one example. There are many studies now, not entirely consistent, by the way, but there are many studies that suggest that there is either greater numbers of mast cells or a mast cell activation in at least some patients with IBS. So this idea of mast cells playing some kind of a role is certainly a reasonable hypothesis that remains to be definitively proven. The last thing I'll just say, and I'll stop, is that there is also some evidence to suggest that drugs that either have an impact on mast cell stabilization or histamine activity can also benefit IBS. So there are a couple small studies with chromal and sodium. Mm-hmm. There are studies with ketotifen, which has activity against mast cells. And so there is some, and also there's a large study looking at the tricyclic antidepressant, amitriptyline. Well, remember that amitriptyline has fairly potent antihistaminic properties. So one of the mechanisms by which amitriptyline may benefit IBS may actually be through antihistamine effects. So there's a lot of sort of smoke out there, you know.
What about histamine degrading enzymes?
Sorry?
What about histamine degrading enzymes that people are taking now? DAO or...
Yeah, I don't know of any work that's showed a benefit of that, but I certainly know that people are doing that.
Yeah.
Yeah.
Yeah. Okay. All right. I'm gonna jump ahead on a couple of things here because I want to save some time for some really specific, important questions, and then give the time for the audience. Dr. Mayo, though, I just wanted to visit this real quick. I think it's an important topic. The research suggests women are about 1.5 to 3 times, depending on where you look, more likely to have IBS, as well as typical concomitant trait anxiety. What are your thoughts on this? Do you agree with that? Do you think that that's accurate, and why?
Yeah, so we've been fortunate to have a center grant from the NIH, Office of Research of Women's Health, for the last 20 years, just in the middle of renewal of that grant. I don't know if it will be compromised by the political changes that have happened. Yeah, there's I would say not just gender, but sex and gender difference. So sex referring to the biological differences, and gender more to the, to the behavioral components of females. And in both aspects, so the gender difference is even higher. The people that visit the healthcare system that have IBS, for IBS or other symptoms, I think is close to 10 times, between 5 and 10 times higher. The actual sex differences are in this range, 1.5 to 2. And we've studied many aspects of that question. So including the microbiome, including the stress responsiveness. Clearly there's a difference between men and women, how the stress system operates and what attenuating factors there are, like estrogens are an anxiolytic and stress-reducing hormone in the brain. So to make a long story short, yes, there's definitely this difference both in sex and gender. The actual causes, other than what I mentioned to you, that has a lot to do with estrogen biology, possibly with the microbiome. There's a difference in microbial composition and metabolites of the microbiome. I wouldn't say this is where I would use the answer that people, or this sentence that people often use. We don't know the full story, why that is. And certainly in terms of therapeutic implications, which is obviously the most interesting thing to this audience, there is a difference. Women are generally more aware to interoceptive signals from the gut, from other parts of the body, and are more likely to report these as symptoms. It goes from the menstrual period to things that happen to their gut. So there's definitely a fundamental difference of how women experience the body and respond to signals from the body. I think that sort of gets to the core.
And more likely to seek care.
Yeah, they're more like to seek care. And that is most likely an adaptive behavior because, there's been this interesting book on the stress response, 6 differences in the stress response that women tend and befriend during stress, a behavior that's activated by sex hormones. So they stick to, they don't run away, they don't fight, they stick together, and which is good for the offspring, protecting the offspring, whereas males go out and fight or run away, so the fight and flight response. So there's a lot of these general differences in biology that I think have to do with ultimately how IBS presents differently.
Well, I definitely want to cover a little bit more about the microbiome and the microbiotic composition in particular before we do audience Q&A. There's a lot of things, obviously, that affect the gut microbiota historically in our past and in our present. Our birth method, our diet, early diet, our current diet, medications we may have taken in the past or are taking now, environmental pollutants, stress, and the like. And it's a complicated business, right? We know the gut microbiota, all these microbes down there. It's a very complicated arrangement, and there's a lot of things going on. We have multiple microbial ligands hitting different human targets. We have microbial metabolites, short-chain fatty acids, neurotransmitters, secondary bile acids, proteases, right on down the line. And as this all unfolds, it can have physiological effects in central nervous system processing, barrier function, visceral sensitivity, motility, and many things. And there is stuff emerging. We see this is a pretty new paper here in the American Journal of Gastroenterology, 2024, showing pretty consistent elevations in Staph aureus and IBS, combined with lower levels of things like the keystone commensal FPRAU, or Faecalibacterium prausnitzii, for instance. We talked about the Klebsiella aerogenes issue with histamine. So there's stuff out there, but really there's an inconsistency. There's association level findings that are conflicting sometimes. There's really been no specific causative relationship with a specific microorganism or microorganisms in IBS. Maybe you disagree with that everyone's sort of coalesced around. Can the panelists share their thoughts on the GI microbiota and IBS in general, as well as any experiences in manipulating the microbiota specifically to try to treat IBS?
Yeah, I don't want to do all the talking, but my personal view on this, there's hundreds of papers out now on associations of altered gut microbiome with IBS symptoms. So these observational studies do not really allow us to make causal implications, saying that these microbial imbalances cause the IBS symptoms, because it could equally be the other way around, that the increased stress reactivity of an IBS patient changes the composition and the function and the gene expression of gut microbes, which we know from many studies. Many of these studies are flawed, partially because the techniques that were used initially to assess microbial diversity and also their function, which is really the main thing, how they express their genes, which metabolites are being produced. So I would almost say that 90% of the published literature on this topic, you can't really take for really proving a causality or a causal relationship to the microbiome. I think there's certain areas that are very obvious and very plausible. One is this gas production by some microbes when they break down complex carbohydrates. And if you have a hypersensitive gut, clearly that will cause symptoms of bloating and distension and gas. I would say that's almost, the one situation where I would say there's definitely a role for the gut microbiome in this disorder.
Well, I bring this up almost as the elephant in the room, right? In the functional integrative medicine space, I think there's been a lot of exposure to the SIBO model, right? This overgrowth model, this overgrowth dysbiosis model, particularly higher up in the gut, and, treat it. Treated with sometimes rifaximin or Xifaxin or, a non-specific, antimicrobial agent, which may or may not be a healthy thing to do, right? We generally don't like giving a lot of antibiotics, but all of a sudden in this case we want to give antibiotics, right? Or a lot of times we treat it a little bit more subtly or functionally with standardized botanicals, volatile oils, and then combinations of pre and probiotics and fixing barrier integrity, the whole 4R, 5R sort of approach that we know in functional medicine. And a lot of us get good results a lot of times doing that. But you also see a lot of treatment failures, particularly, at least in my opinion, with the rifaximin, Xifaxin kind of approach. A lot of people get better for a month, and then they get worse again, right? It's almost like they have a refractory overgrowth. So, but that seems to be the predominant story that's heard in functional medicine. Is that the opinion of the researchers in gastroenterology? Because I'm not sure we're hearing all sides of the story from the greater gastroenterology research community.
Well, if you really look at the literature on this in the GI literature, what you'll see is that there's tremendous controversy.
Right.
There is not universal agreement one way or the other. There's certain things that we know, by the way, and then there's a whole bunch of things we don't know. What we know is that in patients with IBS-D, if you give them rifaximin, around 40% of the patients will get better, and there's a 10% gain, therapeutic gain versus placebo. We know that. There are multiple large randomized controlled trials that show that. But we also know that if you wait for a few months, the majority of those people recur. And what we don't know is, we don't know how it works. Is it really affecting dysbiosis in the small bowel? Is it somehow affecting microbiome in the colon? We have no idea what the effects of, you can imagine that giving rifaximin to a patient with IBS once or twice over years is probably not a big deal. But how about these patients that you described that come back every few months with recurrent symptoms and are getting rifaximin over and over and over again? And even worse, they're not getting rifaximin. They're getting Cipro, Augmentin, Bactrim, tetracycline. That is literally like carpet bombing your microbiome every time you do that. And we have no idea whether that's safe over the long haul. So you do have to realize that there can be some short-term, usually transient benefit to using antibiotics. And if it's like, every now and again, it's probably not that big a deal. But if you're having to do it multiple times per year for many years in a row, I'll tell you, I'm very cautious about doing that. And I'm one of the authors on the New England Journal paper for rifaximin. I absolutely do believe that for some people it's can provide tremendous symptom relief. But I'm scared of the fact that we don't know what repeated long-term use of any antibiotics, including rifaximin, might lead to.
And what about making that determination on breath tests, which notoriously have a lot of problems, right?
So this is a huge raging controversy right now. In fact, there's was just an opinion piece published by a group of very well-known gastroenterologists that absolutely took to task the theory of SIBO as it relates to IBS, and came out very strongly. In fact, it's a position statement from some of the motility societies saying that they don't believe in that theory and they don't feel like you should ever use breath testing to identify patients with SIBO. Now that's opposed by lots of other experts in gastroenterology that feel otherwise. Bottom line right now, this is my opinion, I'm probably sit in the middle, somewhere in the middle on this, is that I don't think we know. Because here's the thing, is there are several small studies which suggest that if you do a breath test and you get a positive result, you're more likely to get better with antibiotic therapy, specifically rifaximin, than if you have a negative breath test. But these are small studies, largely uncontrolled, and so it's supportive evidence, but not definitive evidence.
Right, and breath tests are hard to control the sample. It's hard, you know, the oral microbiome can confound them, many other things can confound them. But a lot of people are parsing IBS into, you know, ISO based on which gas comes out in the breath test, and a lot of people think that's how all the gastroenterology thinks.
Not at all.
I think, and that's not the case, right?
This is still, we need more high quality literature on this topic. It's an interesting hypothesis. There again is some smoke here, but we need to figure out whether there's fire or not. And so it's going to take a little more time to sort this out. By no means is the literature definitively in favor or against this stuff. That's my opinion.
Well, I put this piece, yeah, go ahead.
I can't help, it's one of my favorite topics, and I'm so glad we're on the same wavelength here. So there's some general principles. I think we overprescribing way and above what should be prescribed in terms of antibiotics. Not just children with upper respiratory tract, viral upper respiratory tract infections, but now we have an adult condition with SIBO. I've seen patients that come from across town, you know, one of the centers of SIBO and rifaximin promotion, and that man has had 12 courses of rifaximin. Every time he gets it, he gets temporarily better, then he comes back, and he would still go back, even though I explained to him the whole risk of damaging his microbiome in the long term, he would still go back. So I think the principle of reducing antibiotic use in general, both in children and in this new indication in adults, is number one, I think, because we have been attacking our microbiome health for decades now with antibiotics, and it keeps increasing. So I don't want to sound like RFK, but I think this is definitely one of the areas I think that needs to be changed.
What about the idea, you know, in functional and integrative medicine, we tend to not use the sledgehammer, but kind of use smaller hammers sometimes more functionally around different targets. So an example of that in something like this would be instead of rifaximin or xifaxin, or rifaximin or xifaxin, we would use some botanicals that are standardized that we know are a little bit more sparing to the beneficial organisms and the commensals, and a little bit, you know, can still, you know, do some things to move the microbiome composition around and suppress some opportunistic organisms that may be causing symptoms, and then backfilling with probiotics and prebiotics and dietary changes and maybe some barrier integrity, rejuvenation.
I mean, this is
What is that?
Something science is working on. These targeted microcidal agents that just target one microbial.
Yeah, that would be a
strain
whole
or species.
different.
So it will take a while before those come online, but I think that may be one answer to this issue.
Yeah.
The other thing that I see a lot, and this is I'm a clinician, so I see patients. I don't do research. I don't write research papers. Is I think that the motility of the gut, and when you have these refractory SIBO patients, and it might also be small intestinal fungal overgrowth. That's a whole topic unto itself because we don't really have a way of fully identifying that. I think it's often related to gut motility, and a variety of different things can affect gut motility. Chronic stress can do that. Autoimmunity to the enteric nervous system in the gut. And so you're having normally you have constant peristalsis, and I think that there are some people, for whatever reasons, that they're not having that, keeping the trains running on time.
Yeah.
David, can I say one more thing on this? I think this is a really important point. Is if you have a patient that had a positive breath test and you think have SIBO, and you treat them with antibiotics and they get completely better, and then they recur like very quickly, like within a matter of weeks. And we all see patients like this. make sure you interrogate those patients very carefully to make sure they don't have small bowel diverticulosis, an unexplained stricture, a malignancy. You know, there are a small percentage of patients that truly have bacterial overgrowth that recurs very quickly, and those patients you should not assume have IBS. You should do a detailed small bowel study to make sure that there's not some other anatomical or functional explanation that leads to this recurrent SIBO.
I did put this paper in here just to look at, you know, what the consensus out there in the research is on this. And I don't really have a horse in the fight. I'm kind of in the middle on this as well. But it says here, critical appraisal of the SIBO hypothesis and breath testing, a clinical practice update endorsed by the European Society of Neurogastroenterology and Motility and the American Neurogastroenterology and Motility Society. And they basically say after 2 decades, this hypothesis remains unproven. Moreover, it has led to serious unintended consequences, namely widespread use of unreliable and unvalidated breath tests as a diagnostic test and SIBO, and as results, overuse of antibiotics. They say it's time to reject this hypothesis and reliance on breath testing. Are you guys willing to go that far, or are you?
I'm not, actually. I think this is not doing the field a favor. I think that what we don't know is that we don't know right now.
Right.
And so rather than saying we should just abandon this whole thing and there's absolutely nothing here, we should be saying what are the right questions that we should be asking,
Yep.
and how do we investigate those to get to the answer. So I don't agree with that. I do agree with the concern. I definitely agree with the trepidation and caution, but I don't agree with this idea that we should completely reject the hypothesis.
You mean science evolves and the science isn't settled?
No, it's not.
Trust the science.
Yes.
Trust the science.
All right, well, we had a couple of things on genomics. You can look at the slides on that, but I did want to open it up for any audience questions. So I'm not sure how we're doing this. I think line up. I think there's a microphone. There you are, Woody.
Hi, great. This is a fantastic panel. Thank you all so much. It's so enlightening. I have a question if any of you, or what you think of the use of peptides, either larazotide as a tight junction regulator or the oral form of BPC 157.
Want to go ahead? I mean, the literature that I know of is with glutamine. You know, there's a very nice randomized control trial by Nick Verne and colleagues from Louisiana showing that high doses of glutamine, 5 grams 3 times a day, improves intestinal permeability, and that correlates with significant symptom improvement in patients with post-infection IBS. And so there's been an extension of that study to a number of other agents that may impact on intestinal permeability. I'd like to see some reproduction of the data because literally there's only that one study. There is another study in post-infection IBS not focusing on permeability with actually steroid therapy by an investigator from the UK named Robin Spiller, who actually did not find a benefit from steroids. So I think it's a fascinating hypothesis, makes some sense, but right now there's not a lot of literature in support. There's a lot of animal data, there's a lot of translational data, but not RCT data as of yet.
In terms of peptides, I've had clinical success in a number of patients with BPC 157. Which is they call it a healing peptide, and you can use it for a variety of different conditions, from leaky gut to gastritis to inflammatory bowel conditions. And I think it was, if I'm not mistaken, David, wasn't it? It was discovered in Russia.
Yep.
Yeah, and
along with epithelin and a lot of the peptides
and it's
out of Russia. Yeah.
I think you can get it as a supplement. I think you can't get it IV anymore. I think you can only get it for whatever reason orally, but BPC 157 is something that I use a fair amount in my practice for healing.
Yeah, and my understanding, that's one of the few therapeutic peptides that there are more emerging now that you can orally administer, but it's really for gut applications, not systemic because
Right.
it's
Yeah.
pulled up by the enterocytes and used.
Yeah.
But that brings up a follow-up question I had on here. I think it's worth asking because it's a follow-up to this sort of therapeutic agent question. Do you see any changes likely in the past and the current tendency for drug developers to develop agents for IBS more based on descriptive and symptomatic features of the disease versus this new emergent systems biology-based gut-brain thing? Are they going to change directions on the kind of agents they're trying to develop? Do you have any insight into that, or you think that's the case?
Well, I mean, there's some really exciting stuff going on right now. I don't know if you saw the paper that was published by Vanda from Turkey that actually looked at personalized supplement recommendations based upon microbiome and metabolome analysis of the stool. And it's actually the first well-done randomized controlled trial that I've seen that suggests that there really may be something to stool microbiome metabolomic analysis and then a personalized supplement regimen. There's also, we just last week just published a very large randomized controlled trial showing that IgG-based elimination diets are highly effective in IBS-C and IBS-M patients.
Based on IgG testing, IgG4 testing?
Based on IgG, and this was literally...
That's blasphemy.
I know, and that's the thing is, this is the first large, high-quality study to look at that, using an assay that was developed specifically in IBS patients. And somewhat surprisingly, it shows very positive results.
Excellent. Okay, we have another audience question.
Hi, yes. I just had a 16-year-old girl that was diagnosed with eosinophilic esophagitis and celiac, a lot of IBS symptoms. And I put her on a protocol. We did IgG testing and really so many food sensitivities, and we eliminated them. And she went back to her gastroenterologist, and now she isn't supposedly in remission, but having a lot of gas up her, and they didn't do breath testing, but they suggested SIBO. But I don't know where to go from here. And I didn't know what you thought about like success rates with elemental diets with SIBO. What's your feeling on that?
Do you want to comment? So there is a small randomized controlled trial from Cedars on elemental diets for patients with SIBO, suggesting that it provides benefits. The problem with an elemental diet, as you know, is it really doesn't provide a long-term solution. It's highly unpalatable and difficult to adhere to beyond a very short randomized controlled trial. So it's not been something that's been a pragmatic kind of option. I will say this, there are commercial entities that are developing palatable elemental diets. And I'm dying to actually get my hands on this and play around with it a little bit in some of these patients that really have refractory Crohn's disease, refractory SIBO, if you will. So it remains to be seen whether the patients will be able to adhere to it. But there is some literature on that. I don't think from a pragmatic standpoint it's a realistic option.
Okay.
Hi. Thank you so much for this wonderful presentation. I'm wondering if you guys would comment on what you think about current stool tests that are used for diagnosing SIBO, leaky gut, and other things. I see that there's a lot of controversy as to how to truly diagnose SIBO with breath tests. So I wonder what your thoughts are. Many of us integrative functional physicians are using this test, but I wonder your thoughts about this. Thank you.
That's a very dangerous question.
You just threw a grenade in the room.
This is what I would say at the current time, is that I think it's really important for all of us to carefully scrutinize the literature upon which these tests are based. In other words, is there data from at least animal studies or translational studies that would support the hypotheses that these tests are trying to answer. Is there randomized controlled trial data? There's starting to be for some of these tests, is my point. And to me, if you're going to use those tests, you should stay with the ones for which there is actual evidence. That said, it is really important to say that a lack of evidence doesn't mean something doesn't work. It just means we don't know.
And I would say there's also what a lot of, I think, clinicians don't understand because we just don't get this in our training. There's fundamental differences between the methodologies that are used in stool testing, right? There's various types of sequencing, and it's very good for what it's good for, right? Which is generally to do large analysis over large population groups to try to determine what is the overall composition of the GI microbiota in people with rheumatoid arthritis versus without, or with this or without, or people who use this diet or that diet. But sequencing was never, it's not diagnostic, it's not quantitative, it's relative of the DNA catch, right? And the sequencing that's used in a lot of research studies is sequencing that's done at big academic centers. They have time, they have money, and it's computation, it's highly computational. It takes a lot of computer power to sequence with the right number of reads to get the high level of fidelity that you get in these research type of papers. That's not the same sequencing you're getting when you pay $99 and send your stool sample off to a direct-to-consumer sequencing thing. They can't get the throughput. They'd never be able to do it commercially at that kind of price. So it's not apples to apples, even though it's both sequencing, right? And there's various types of sequencing. There's 16S sequencing, there's transcriptomics, there's all kinds of different things. And they all are good at certain things. But they were never really meant to make medical decisions. Like, is there pathogens there, for instance? And if so, how many of them, and should it be treated, right? That's a whole different question when you're dealing with one individual and you're trying to make a treatment decision versus looking at populations and comparing them and crunching data in a computer and trying to come up with, answer research questions. So one's like looking out of the plane at 30,000 feet, and the other's like looking out of the plane at 1,000 feet. It's a whole different animal. With something that's quantitative, you got to learn from all the sequencing data that's out there, and then curate what your targets are with quantitative targeting, and then answer that with high fidelity and high confidence. They're both very useful. They're just very different, and I don't think as clinicians we get any kind of training on that. Maybe now they do. We certainly didn't. It wasn't even around, right?
Yeah. I'll just sort of also make a comment in terms of the human microbiome. And I think, based on my reading of the literature, the more diverse your microbiome is, the healthier you are in general. And we're just starting to understand the microbiome. And the more I study it, the more humble I am because I don't know a lot. Yeah. And I think the things that are affecting our microbiome, which in turn is affecting IBS and irritable inflammatory bowel disease and even Alzheimer's, there's a whole bunch of different things that are connected to the gut microbiome. And what we're doing is we're losing our diversity, primarily because we're eating processed foods, we're not outside, we're not digging in the dirt, we're not eating apples that are unwashed, and we're being laced at a low level with toxins, namely antibiotics in the food chain, glyphosate, which is supposed to not affect humans, but it does affect the microbiome through the chitinate pathway. So there's a lot of different things that are causing us to de-evolve our microbiome. And I always like to remind my patients that when you sit down and you eat your supper, you are feeding your commensal bacteria. And commensal in Latin means that you're sitting down at the table with. So I always like to remind my patients that you're not just eating for your own energy and your own pleasure, but you want to be feeding these little characters. Like you were talking about the evolution, they got a nice warm place to live. We actually act as like an airplane. We can carry them around the world, and we feed them. So they help us, we help them. And
they're like my teenage boys.
Yeah, I couldn't agree with this more what you just said, and I think that's gives you a very simple answer how to eat and what to eat, because if you focus on what's optimal for your gut microbial diversity and richness, both of those things, and avoid all the exposures to these things that you mentioned, that's all you need to know. You don't need to know, all these specifics that are being promoted on social media of this fat diet, yes, and tomorrow another one. It's actually a very simple answer, the basic answer. You do want to personalize this to an individual, but the general rule is pretty clear. And I think where we're going to get with increasing attacks on the microbial diversity, we don't know. It's uncharted territory. I mean, it's just like extinction of a lot of species and insects. We don't know what ultimately this will lead us to what kind of a world and to what kind of diseases. But, you know, just adding to the things that you mentioned, microplastics, probably one of the latest that has received attention. We still have no clue whatsoever what this does to the microbiome.
Well, we don't even know yet what is a normal, healthy microbiome, and it's different in different places of the world, on different diets, on in different subpopulations. But Todd, you brought up a really good point. I mean, it's what we eat that really has the most determinant over our microbiome, because a lot of people, especially the general public, but I think even a lot of clinicians, they think these probiotics are, remember they use words like repopulate, reinoculate. It doesn't. They make up of such a small percentage of the normal human microbiotic composition. They're very powerful clinically because they're signaling agents, right? They do things, but you're not sending in ground troops and rebuilding all your beneficial bacteria. Most of the conventional probiotics we use, they're things that have come in through the diet. They're exogenous microbes that we can put in to do something, but they're not the building blocks of the main part of the microbiotic composition. That's your anaerobic commensals, by and large. And although it's starting now, they're starting to be able to manufacture those and put them out, but it's still really fuzzy around the edges there. It's how we eat that really determine our microbiome. It's not
also one comment to what you said is so the peoples in the world that have the most diverse, the healthiest microbiome, the most diverse and richest are people that are living in almost prehistoric conditions in the Orinoco and Amazon jungles that has been studied by a person, Marty Blazer and his wife. And when you look at how they live and what they eat, they do all the things that we are suggesting to our patients to improve
that we don't do anymore.
There's the physical activity is a largely plant-based diet. There's
fiber, lots of fiber.
Close family ties. So it's
all the blue zone stuff, really, in many ways too.
To me, it's always interesting that having one foot in science, and it's mind-boggling what is happening there right now. I think science has never seen that explosion with techniques and technologies and sophistication. And on the other side, in the clinical realm, and the gap between the simple practical things that we need to know to transmit this to the patients and recommend patients what they should do, to this huge gap in knowledge and information that is created by this vast amount of information that we don't really know how to interpret. We need AI to interpret this science explosion.
Yeah, and I'll just add one other question. The one thing in my experience, and I don't do it, is fecal transplants. And when you look at transplanting stool, obviously in the United States they do that for C. diff, refractory C. diff infections. But there's a brilliant gastroenterologist out of California, Sabine Hazen, who is doing a lot of work on the microbiome and has amazing clinical cases of reversing autism, alopecia totalis, Alzheimer's disease, depression, you name it, using stool transplants. Now, the question is, where do you find the good shit? And that's her big question. It's
well, all I know is you go to that guy's house, if he's making margaritas in his blender, don't drink them. No, I'm all kidding. No. But, FMT is an interesting thing because you're not giving one organism or a couple organisms sourced from different places. It's a whole community network effect that you're putting in there, right? You're going to get more engraftment. You're going to get more functionality.
And it moves the needle like you wouldn't believe. It's amazing.
We have two more questions? Okay. Let's get those done and then we'll wrap up.
So we see in the literature a pretty tight intersection between trauma and disruptions in the gut-brain microbiota axis, particularly complex PTSD. So I'm just wondering how you assess for that in your clinics if you look for ACEs, and how, if you treat that differently when there's been a complex trauma narrative.
It's right down your alley. That's Emran's alley, right?
I didn't quite understand the question.
If someone has complex PTSD trauma, how does that change the way you would assess them or treat someone with IBS? Is that right? Yeah.
So,
yeah. Do you assess for trauma and past traumas, adverse life events, things like that, as far as your management of patients that come in with IBS
yeah, obviously,
symptoms?
I mean, this is one of the key pillars. I mean, this assessment, what happened, how did an individual life start? Human biology is very good in programming a lot of things early on in life. It starts actually pre-conception, what experiences the mother has before she gets pregnant, when she's pregnant, delivery, the first few months in life. All this is programming of the gut microbiome, the immune system, but also the brain. So I mean, the brain takes the longest time because, you know, the prefrontal cortex, I think, could take 18 years before that develops, or longer. Longer, most likely.
Sometimes never.
So whatever happens during that time, be it antibiotics, be it exposure, you know, to negative factors, diet, but emotional trauma being one of the most important ones. And that, like years ago, this started with sexual abuse. So Dr. Rossman published a pivotal paper at the time. But in the meantime, we know sexual abuse is a very small component of this early trauma. Can be verbal abuse, it can be physical abuse. And that makes that individual more vulnerable and more stress responsive for the rest of his or her life.
Yeah.
So to assess that, I think, is a key. Any clinical assessment should start, I start with a questionnaire, always. Most patients will confirm their questionnaire, but some patients come to you and say, no, I had a great childhood, and, you know, but then it turns out when you get to know this person better, there were actually some major traumatic events, and so yeah, I would agree with you. A major risk factor for all the things we've talked about, the brain-gut axis. I personally think the brain-gut axis is programmed in the first few years of life, including pregnancy.
Mm-hmm. Todd, did you have one thing?
No, and I was just going to say,
question?
it depends. I think it depends when the trauma happens. You're right. The early childhood.
Yeah, when
trauma
your nervous
even
system's
pre-verbal,
neuroplastic and everything. Yeah.
When you're pre-verbal and you don't even know that you went through trauma because you can't articulate because you couldn't speak at the time. And I think that's different than someone who has trauma, you know, because they were held up or raped or, you know, a car accident or something like that. But I just had a fortunate to meet the author whose name escapes me, but it's called The Body Keeps the Score. And what, yeah, yes, thank you. And he is doing a lot of ketamine-assisted psychotherapy for trauma, PTSD, refractory depression with amazing, amazing success. So and I wouldn't necessarily call ketamine-assisted psychotherapy a psychedelic, but it's in the realm of psychedelic-assisted therapy, and there's incredible potential for helping these people that nothing else fixes. Nothing else will fix it. And we see that in adults.
Thanks. Jill, you want to go? Last
Yes,
question.
thank you. So following up on the probiotic issue, I hate to say it's a crapshoot. Whoops, a bad joke.
Yeah.
But the question is, I mean, there were so many probiotics out there, and we do the stool test, GI stool effects, whatever, but how do we know really what to give, how many billion, you know, whatever, and, you know, do we give Akkermansia, do we give, you know, Culturelle, do we give a multi-strain probiotic, and for how long? So, and do we people develop tolerance? So it's yeah.
Yeah, I mean, I could tell you my bias is away from the magic soloist. You know, you're trying to find, I need to use this genus, species, and strain. That's the magic one. That's got this literature. And I think it's an orchestra community effect. I really do. And I think FMT backs that up. So I think there's a lot of research going into now trying to replicate that almost with like oral delivery, including of anaerobes. you know, the foray now into, as you mentioned, one anaerobic commensal organism. That's that's one bug, right? And that has a U-shaped curve. That has an envelope. I mean, too low of Akkermansia is associated with metabolic issues and obesity and many other things, but too high has at least been associated with MS and autoimmunity. So it's not like give all you can, right? And even in regular probiotics, I really don't think it's a numbers game. It's a signaling game. I think Sig Begmark said probiotics are like pixie dust, right? Just a little. That's all you need. Like your 100 million or 100 billion, you know, I have 50 billion. Well, mine is 100 billion. Really, you're nothing. Mine is 200 billion. That's like saying I'm going to dump a shot glass full of blue dye in the Pacific Ocean to change its color, or no, I'm going to dump 2 shot glasses. It's inconsequential at that point. I don't know if you guys agree with me, or feel free to disagree. You guys know more than me about this.
Yeah, I mean, my thoughts on this is, I mean, obviously we're just at the beginning of these evaluations, and not the evaluations, we have the technologies to do it, but not in terms of interpreting and identifying causal relationships. We have some simple things, you know, like the tests that look at, the older tests look at who is there, which organisms are there, and in general, the good ones are the ones that produce butyrate, short-chain fatty acids, because it's anti-inflammatory, so that's an easy one between the good and bad microbes. There's now some new tests coming up and existing using something called metagenomic analysis, where you actually get the gene expression of the microbes and ultimately the products. That's the most relevant things. What is the community of your microbes? What products are they generating, and how does that relate to your health or to your disease? I think some of these tests are available. People also use now, some of the newer tests use AI to interpret the findings and give you an easier and more reliable interpretation. But I would say we're still early on in the course. This will ultimately become a standard in evaluation, just like your serum cholesterol, and everybody will know what it means. So right now, you know, people get these pages and pages of
you do see supposed AI or machine learning interpreting some of these things, and then you find out it's low fidelity sequencing. So it's only as good as the fidelity of the information, right? And everyone calls everything AI now. You need to be careful about that too. So you're right. There's legit stuff going on in the research. Sometimes the stuff that's first out there commercialized is, you know, not exactly what it says it is. So
just to follow up on your mentioning of the microbiome metabolites, and I sort of indirectly fell into this when I was studying C. diff. So we know that if somebody has C. diff, their microbiome is usually it's triggered by an antibiotic use, and we know that for refractory C. diff that we can use a stool transplant, and the mechanism for that is actually secondary bile acids. So our bile acids are produced by our own liver, and then it's acted upon by the microbes. And when you take antibiotics, you actually deplete these. They're not really well understood, but you deplete these certain microbes whose action on the bile acids create these secondary bile acids, and that's how C. diff gets cured through a stool transplant. It's the secondary bile acid production by these little critters that are, you know, part
stool
of
omics is a big
exactly,
thing, not
yes,
just the
yeah.
microbes. Val, you're the last question because we do have to wrap it up.
All right, it's just brief. Actually, that was so interesting.
Actually, Joe was the last question, but you come up with your imposing tallness, so or the beard. So go ahead,
sir.
Yeah.
I wanted to go back real quick to what Dr. Lapine was talking about, and emphasizing what he said about microbiome diversity leading to poor health, which is totally true. The number one genetic factor for having low microbiome diversity is being a FUT2 non-secretor, because you don't have all the blood group sugars that are like snacks for your bacteria. Interestingly, I looked it up, there's no decreased life expectancy if you're a non-secretor. So it's like, wait a minute, how can it be reduced health, which we know it is, but somehow they live the same amount of time? So one possible reason. Non-secretors are more protected against H. pylori. Maybe the older you get, the more stomach acid you make because you don't have as much H. pylori, so you can live longer, digest your proteins, and have like an intact gut barrier. But that's non-secretor protects you from COVID, protects you from enteroviruses, a bunch of other things. So it's like a give-take.
Yeah, I'll interject here because I learned about, some of you may not even know what the F2 secretion status is, but I learned this from Peter D'Adamo, and his brilliant daughter, Emily, is here in the crowd. And Peter opened up my eyes to really understanding that our blood type, and the first time I heard about the blood type diet, I said, this is bullshit. I really did. And I told that to Peter. The first time I said, this is like crazy. It didn't make any sense. But once you actually realize that your blood type is not only, which are basically sugar moieties, are not only secreted on top of red blood cells, but they're in all of your secretions, your tears, your mucosal oral lining, and your gut, and they act as signaling molecules and also food for bacteria. And you can realize that our blood type expression is important, and specifically through the fucosyl-2 transferase enzyme, and whether you're secretor or non-secretor affects your risk for infections, et cetera. So
he was ahead of the curve on glycomics for sure.
And also Crohn's disease, like food too. If you're a non-secretor fucosyl-2 transferase, you're at much higher risk for Crohn's disease too. So that's a great point.
All right, thank you everybody. I wanted to make sure everyone knows that Dr. Meyer also has a separate lecture he's doing. Does increased stress responsiveness increase your health risk? And that will be tomorrow at 2:15 in the Grand Ballroom West next door, and that's a CME session. And Dr. Lapine was nice enough to provide this QR code with a bunch of additional research resources if you want to pop this with your camera, but it will also be in the PDF that we provide for this presentation. So thank you very much, everybody. Thank you, panelists.